Hello everyone. Today we are going to discuss another sets of MCQs and one-liners in neurocutaneous syndrome. To start with, all included in neurocutaneous syndromes except A. Ataxia telangiectasia, B. Hypomelanosis of Ito, C. PHACE syndrome, and D. Landau-Kleffner syndrome. So among these four, which one is not there in the list of neurocutaneous syndrome? The answer would be Landau-Kleffner syndrome. Then to know that, we have to know what do we mean by neurocutaneous syndrome. Neurocutaneous syndrome means nerve plus cutaneous skin. Disorder believed to arise from defect in the differentiation of primitive ectoderm that includes nervous system, eyeball, retina and skin. So we may get symptoms related to your nervous system. Not only there will be related to nervous system, but there is some defect in the eyeball, in the retina and related to skin. So if two are there, then that has to be included in the syndrome, neurocutaneous syndrome. So what are the disorders included in neurocutaneous syndromes? This is the list that we have to remember. That is neurofibromatosis 1 and 2, tuberous sclerosis, Sturge-Weber syndrome, von Hippel-Lindau syndrome, PHACE syndrome, ataxia telangiectasia, hypomelanosis of Ito, incontinentia pigmenti, and linear nevus syndrome. So these are the names. Just we have to remember so that we can exclude in the MCQ. Then second, which is otherwise known as von Recklinghausen disease. So among this list, which one is known as von Recklinghausen disease? Answer is neurofibromatosis type 1. So NF type 1 is known as von Recklinghausen disease. So something about neurofibromatosis. These are three types. We commonly know that it is two types, 1 and 2. But in Nelson it is written this is three types, 1, 2, and another variant is there, that is schwannomatosis. This NF1 is also known as von Recklinghausen disease. It is autosomal dominant inheritance. Chromosome number is 17. And NF2, your chromosome number is 22. Chromosome number sometimes it is asked in exam. So we have to remember that NF1 is 17. So how to know neurofibromatosis? The total number of letters in neurofibromatosis is 17. That we can remember. So it is chromosome number 17. And NF2, that is 2. 2 means 2 to 22. Chromosome number 22. Easily we can remember. Otherwise in exam we will get confused. Next, NF1. How to diagnose? 2 out of 7 criteria must be present. What are the 7 criteria? That is most important is your capillate spot macule. 6 or more capillate spots macule. Second is your axillary or inguinal freckling. Third is your 2 or more iris or least nodule. Your neurofibroma. Fifth is your spinal dysplasia or cortical thinning of bones. Sixth your optic glioma. And seventh is your first degree relative with neurofibromatosis. Capillate spot, this is the 100% associated with your neurofibromatosis. There has to be more than 6 or more number of capillate spots macules to say it is significant. Second, axillary or inguinal freckling, it is present around 80% of cases. May not present at birth. Around 3 to 5 years we can get. And iris least nodule, it is around 74% will get, but it is not present at birth. Gradually, as age increases, we will get more number of iris nodules. 2 or more neurofibroma or 1 plexiform neurofibroma to say this is neurofibromatosis. Spinal dysplasia or cortical thinning of bones, and we will get optic glioma. Optic glioma will get around 15 to 20%, and this is the most common CNS tumor in neurofibromatosis type 1. The question may be asked, which is the most common CNS tumor in NF1? The answer is optic glioma. These are some pictures. The first one is your capillate spots. These are 1, 2, 3 capillate spots. Second, your iris least nodules. Third is your axillary freckling, and fourth down one is your neurofibroma. This is for your visual memory. Next, what do we mean by Crowe sign? Crowe sign. What do we mean by the Crowe sign? The answer is presence of axillary freckling in NF1 is known as Crowe sign. We can remember this. Crowe sign is your axillary freckling. Then NF2, this is also known as central neurofibromatosis, and NF1 is known as your peripheral neurofibromatosis. That also you have to remember. Then the criteria is vestibular schwannoma. This is the hallmark of NF2 is your vestibular schwannoma. Other things what we can get neurofibroma, we can get meningioma, we can get glioma, and posterior subcapsular cataract. It is associated around 50% cases of neurofibromatosis. Next, use of selumetinil in NF. This you can get one recent advanced question. Selumetinil is an oral MAPK means your mitogen activated protein kinase 1 and 2 inhibitor. Just we can remember that selumetinil is MAPK 1-2 inhibitor. What is the use? It is used to treat pediatric NF1 patients with inoperable plexiform neurofibroma. It has been seen that this drug will reduce the size of plexiform neurofibroma. Then next question. A 3-year-old boy is referred to the pediatric OPD for hyperpigmented macules. Just we have to concentrate on the catchment area, that is a highlighted area, that is your hyperpigmented macule. This is the clue point that we have to remember. Hyperpigmented macule over the trunk, which were also present in his father's back. That means it is somewhat related to your autosomal dominant or some innatance. Ophthalmological examination revealed hematoma of iris. There means then we can know that that is one neurocutaneous syndrome. Which of the following malignancy is the child is prone to? From the history itself, we can know that hyperpigmented macule, your presence of autosomal dominant inheritance, and your hematoma of iris. This means it could be a case of neurofibromatosis. Then question is straightforward. In neurofibromatosis, then which malignancy in neurofibromatosis type 1 is they are prone to? ALL, second your juvenile myelomonocytic leukemia, third AML or acute monocytic leukemia. What can the answer? NF1, the most common malignancy which they are prone to is your juvenile myelomonocytic leukemia. Next, this is another clinical case. 5-year-old mentally retarded girl presented with multiple forms of seizure. On examination, found to have these are the skin lesions which we got. What are the skin lesions? The first one, what is this? This is asleep macule. This is third one is your Sjogren patches, and this is your adenoma sebaceum. So these three, then seizure. Then what is the neurocutaneous syndrome that we have to tell? The answer is tuberous sclerosis. Then coming to tuberous sclerosis, this is another important topic. Tuberous sclerosis, the gene is tuberculosis type 1 and type 2. Gene is hamartin. Type 1 is hamartin, chromosome number 9q. Type 2 is your gene is tuberin and chromosome number is 16p. We have to remember, no, there is no other alternative. We have to remember type 1 is your 9q and type 2 is 16p. What are the major criteria? Major criteria we can remember: cortical tumors, subependymal nodules, subependymal giant cell astrocytoma, and facial angiofibroma or adenoma sebaceum. Along with this, ungual fibroma, hypomelanotic macules, Sjogren patch. This is that orange peel consistency like thing which will get in the lumbosacral area. That is your Sjogren patch. And what are the other things? Multiple retinal nodular hematoma, cardiac rhabdomyoma, and renal angiomyolipoma, and pulmonary lymphangioliomatosis. These are the major criteria. Everything we may not remember, but most important is your asleep macule, at least 3. Second is your Sjogren patches, and third is your cortical tumor. This we have to remember. Next, what is SEGA and how it is related to cortical tumor? SEGA is your subependymal giant cell astrocytoma. As you know, in tuberous sclerosis, we will get subependymal nodules. These are found alongside of your lateral ventricles, which may undergo calcification. The nodules which are getting that, those may undergo calcification and project into the ventricular cavity, but producing your typical candle dripping appearance like. Then what are the prognosis? These are benign lesions, but in 10 to 15% cases they can go into SEGA or subependymal giant cell astrocytoma, which can block the CSF circulation, requiring neurosurgical intervention. So then here we can remember one molecule, that is everolimus. It is effective in slowing the growth of sega. Everolimus is the molecule recently which it has been approved by FDA, which is used to slow the growth of the sega. Next, drug of choice of infantile spasm in tuberculosis patient. Tuberculosis patients presenting with infantile spasm, what is the drug of choice? It's easy question. That is answer is vigabatrin. Something about vigabatrin. Vigabatrin, it can cause blindness. This is the most dangerous AD. The one AD is there which can cause blindness. That is your vigabatrin. And second molecule of choice which we used to use in a case of infantile spasm is your ACTH. Next question. 5-year-old girl presented with seizure involving right half of the body. On examination found to have skin lesion. So it is a neurocutaneous syndrome. Which neurocutaneous syndrome? You will get such skin lesion, facial lesion along with seizure, partial seizure involving the other half of the body. What is the diagnosis? Diagnosis is your Sturge-Weber syndrome. Sturge-Weber syndrome, where you will get the proton stent. Proton stent contains P will persist. So proton stent will persist. That proton stent. Second is your ipsilateral leptomeningeal capillary malformation. The same side. Suppose we are getting proton stent in the right half of the body, right half side of the face. Then in the right side of the CNS, we will get leptomeningeal calcification. That is the typical is your that is called tram track or rail track calcification. Along with that, we will get same side ophthalmus and glaucoma. Ipsilateral eye, same side. This we have to know. The side where we are getting the potential, the same side will get ophthalmus, the same side will get glaucoma, and this same side will get the calcification. So suppose calcification is there in right side, then we will get seizure in the opposite half of the body. And CT scan is the investigation of choice where you will get tram track or rail track calcification. Next, identify the neurocutaneous syndrome. We can get one MCQ like this. Identify the neurocutaneous syndrome. What we are getting, we will get the tram track or rail track calcification. This is your Sturge-Weber syndrome. Next, which among the following is not true regarding von Hippel-Lindau disease? So A, B, C, 4 options are there. First is your autosomal dominant inheritance. Second is cerebellar hemangioblastoma is a major feature. Third, retinal angioma, which is usually seen, can affect vision. Or it is the fourth one, that is pheochromocytoma, is commonly associated. Among these four, one is wrong. Which one is wrong? That we have to pick up. The answer is retinal angioma, which can affect vision. The retinal angioma which we are getting in a case of von Hippel-Lindau will located peripherally and it will not affect the vision. So something about your von Hippel-Lindau, autosomal dominant inheritance, cerebellar hemangioblastoma and capillary angioma, these are the major features. Because of the cerebellar hemangioblastoma, we will get features of raised ICT, and along with that retinal angioma, which are getting in von Hippel-Lindau, these are peripherally located. So vision is not affected. This we have to know. We have to remember that vision is not affected in a case of retinal angioma, which are getting in von Hippel-Lindau. Other things what we can get is in these are the cystic lesions which will get in kidney, pancreas, epididymis, liver, and pheochromocytoma is commonly associated. These are things which will get in case of von Hippel-Lindau. So coming to the question, the answer is retinal angioma can affect vision. This is the wrong one. It will never, as it is placed peripherally, so vision is not going to be affected in a case of von Hippel-Lindau with retinal angioma. Next question. PHACE syndrome. P stands for what? This is one tricky and very nice MCQ. P stands for what? Is it pheochromocytoma, or is it posterior fossa malformation, or is it persistence of ductus arteriosus, or it is pituitary adenoma? P stands for what? This P stands for your posterior fossa malformation. PHACE syndrome, P your posterior fossa malformation in terms of Dandy-Walker malformation and hyperplasia of the cerebellum. H stands for hemangioma. A stands for arterial anomaly in form of hyperplastic carotid and carotid aneurysm. C stands for quadriceps aorta and other cardiac defect. E stands for eye abnormality, where you can get glaucoma and cataract. So PHACE, P-H-A-C-E, if you will tell PHACES, if another S is included, that S stands for sternal clefting under or supraumbilical raphe. So this just we have to remember, so we can get one MCQ. Thank you. Please like this video, subscribe this my channel, and share this video. Thank you.